Hi, this is Elliot Fishman, and welcome to our latest talk. This is going to be part 3 of abdominal pain in the ED, GU pathology, and this is going to be part 3 of what will end up being a 3-part adventure. Anyway, I mentioned last time bladder cancer is very common, and so in a patient with hematuria, particularly a patient over 60, bladder cancer is something you need to be thinking about. But it's also important to remember, particularly as we see lots of older patients in the ER, particularly patients, for example, who are getting aortic aneurysm evaluations, lots of things with arterial phase imaging, that we may pick up bladder cancer that's totally unsuspected. So you need to be looking very carefully at the bladder. Now, CT is good for detecting bladder cancer. High sensitivity, high specificity, negative predictive value, is good. Very good, in fact. And bladder cancer typically is a hypovascular mass. You can see it here as arterial phase imaging, solid, a little bit of vascularity. This is a 3-centimeter mass. It's fairly large. You can see it both on arterial phase imaging where there's no contrast in the bladder, or delayed phase imaging where there's contrast in the bladder. One could probably see it better when the bladder is distended with contrast, though at times, very dense contrast can obscure small lesions. Now, we made the point previously in this article with Rahman that we do pick up lots of incidental bladder cancers because as we do more and more arterial phase imaging, particularly in the ER, trauma in older patients, aortic aneurysms, and for many other reasons, it would not be surprising to pick up small bladder cancers, which are fairly tiny but vascular, so stand out against the urine on arterial phase imaging. We did a recent paper which looked backwards at patients with diagnosed bladder cancer and found that in a significant number of the cases, the bladder cancer was on a CT scan but not recognized because that CT scan was not specifically for hematuria. A bladder wall mass was visualized in 67% of patients and on 35% of scans performed before diagnosis. The majority were intraluminal. Transverse long and short diameters were 24 millimeters and 17 millimeters, with long dimension between 5 and 59. It makes the point that you will pick up lots of incidental bladder cancers. Again, it's dependent on the age of the population. But here's a nice example. Incidental finding, 7-8 millimeters, anything in the bladder that enhances, no matter how small, it's bladder cancer till proven otherwise. Here's a bit larger lesion at about 2 o'clock on the bladder wall. Again, vascular. It's only 80 to 90 Hounsfield units, but against urine, which is 0 to 10, stands out very nicely. We also should note that with hematuria, we also need to be looking for reasons beyond bladder cancer. Here's a patient with hematuria following catheter placement. I think the patient had delayed or a distended bladder. Wasn't clear why, so they put a catheter in. But look what happened. Anytime you put a catheter in, it was a difficult placement, but you hit the back wall, and now you have active bleeding in the bladder. So one of the things for hematuria, we always think about tumor, can be infection, but can be trauma, including iatrogenic trauma, which is very nicely shown in this example. Now, we had recently a host series on renal cell carcinomas, so I'll just make the point that 40% of renal cells present with hematuria, 40% with flank pain, and you can see some of the other possibilities. So it's not surprising that these patients will show up in the ER, either with gross hematuria, maybe weight loss, maybe fever, or flank pain. We talk about the fact that microscopic versus macroscopic hematuria, that with microscopic hematuria, the chance of cancer is small. With macroscopic hematuria, the cancer chance is high, even in younger patients. We've spoken about the importance of multi-phase acquisition for lesion detection as well as lesion classification, clear cell versus papillary versus chromophobe, as well as for correct staging. We note how clear cell is typically around 150 Hounsfield units, and papillary closer to 62 Hounsfield units. And so if you say anything under 100 is papillary and anything above 100 Hounsfield units is clear cell, you'll probably have a 95+% accuracy. Here's just a simple example, non-contrast scans. Solid mass, right kidney, very vascular. Clear cell renal cell carcinoma. It's the periphery of the kidney. Partial nephrectomy should work very nicely. You can see that the arterial phase imaging is what allows you to make the diagnosis of clear cell. On the venous phase imaging or excretory phase imaging alone, it still could be a papillary renal cell carcinoma. We've spoken how we use cinematic rendering for detecting tumors, staging tumors, and preoperative planning, very nicely shown in this example, where the patient eventually underwent a partial nephrectomy, which is the goal. We do not want to be doing total nephrectomies if we can avoid it. Another example here of a large renal cell, very vascular, obviously a clear cell with invasion of the left renal vein, very nicely shown. The neovascularity in the tumor is shown nicely as well, and volume rendering shows the thrombus in the renal vein and tracking just into the patient's IVC. And on the excretory phase imaging, the solid mass, excretory phase imaging shows some KLCL involvement, but it is on the earlier phase imaging that we learn a lot more about the patient's tumor. Briefly, I'll just mention papillary are the lesions that are often the smaller ones, are the ones that are incidental, where often management now for lesions under 2 cm, surely 1 cm or less might be simply to follow the patient, as these lesions are not very aggressive. They're ideal for nephron-sparing surgery, if that's the method you want to do. And again, very important to look at the appearance of the lesions, not very vascular. These are often the lesions that are undercalled. Someone looks at a CT and says, oh, this must be a high-density renal cyst, or just it's so smooth, and those are often the papillary renal cell carcinomas. I do want to make the point that papillaries are not necessarily small. Here's a 7-centimeter mass, solid, homogeneous, that was a papillary, but it's a large tumor. Very nicely shown on the excretory phase imaging as well. And you can see it here very nicely next to the ureter. Now, in terms of urothelial cancers, again, if you're looking at gross hematuria, it's one of the presentations. The majority are transitional cell carcinoma, a touch older population than renal cell, but pretty much the same, more common in men, and it's one of the tumors which can have multiple sites of disease at presentation or at recurrence. One of the things about transitional cell carcinomas, if you don't have excretory phase imaging, you can easily miss these lesions. And in the ER setting, often the studies are single phase. So if you need to be very careful that if a patient has hematuria, make sure you surely get delayed phase imaging. Without excretory phase imaging, you will miss transitional cell carcinoma. Now, the appearance, we spoke about this in the dedicated talks on the kidney, are variable from tiny lesions and strictures to large bulky masses to infiltration of the kidneys where it looks like a renal cell carcinoma. Here's a nice example of a lesion sitting in the left renal pelvis. Faint calcifications. Is this inflammatory? No change in enhancement to any great degree on early phase imaging. But as you look at the venous phase, you can see the infiltration of the pelvis in the left kidney with the calcifications. And on excretory phase, you very nicely see the distortion of the pelvis, the infiltration, very classic for transitional cell carcinoma. This also emphasizes the point we've made many times, how MIP imaging is very valuable in looking at the kidney. Or another example here where there's function of both kidneys, not a whole lot of difference, but look at the soft tissue mass sitting in the left renal pelvis. You can see it again on the coronal views. If this was a single phase study, you still should make the diagnosis. Always look carefully at the renal pelvis. You may not see hydronephrosis, but look for increased density. Here it is on the 3D imaging. You see the soft tissue mass tracking to the lower pole calyces. Very nicely shown again on these images. And of course on the excretory phase, which is critical, You can see the mass. You can see the distortion of the calyces to the lower pole, classic for transitional cell carcinoma. And here it is again, very nicely shown, again on the MIP imaging. Again, one more set of views. So TCCs can present in the ER. Again, it's one of the possibilities when you're thinking about macroscopic hematuria. Now, I'll also mention lymphoma. Again, I don't want to go through all the tumors, but just to make the point that sometimes we will see solid masses, and patients with fever or abdominal pain can present with lymphoma. It may only be in the kidney or only adrenal. Most commonly, it's kidney, and it's liver, and it's spleen, and it's adenopathy. There's a range of appearances for lymphoma, most commonly bilateral, but not always, solid masses or multiple masses, infiltration of peri or pararenal space, and bulky adenopathy are all common. It's not uncommon for us to see renal lymphoma involvement in a patient with no lymphoma, but it may be the initial presentation. It could be the only finding, but more typically, it's part of multi-organ involvement. Here's just a nice example of diffuse infiltration of the kidneys bilaterally with lymphoma. Again, you could think a little bit about infection. You could think about amyloid. You could think about a number of things, but you got to be thinking lymphoma as well. Here's a classic example of perirenal space extension, periaortic nodes, involvement of the kidney in a patient, non-contrast in contrast with lymphoma. Or in this case, where the mass in the right kidney is probably more suggestive of renal cell carcinoma, particularly with the lack of adenopathy or other organ involvement. And I would probably be going with a renal cell, maybe a clear cell, but here's a good example of the overlap with lymphoma. Again, nicely shown in this example, lymphoma involving both kidneys. Renal cell classically is one kidney. Mets can be both kidneys. Lymphoma commonly going to be both kidneys. And it often has a lot of unusual appearances. If this patient was febrile, you could be thinking about microabscesses if the patient was immunosuppressed. But here's lymphoma, normal-sized kidneys, but multiple lesions nicely seen in both kidneys. And here, really impressive infiltration of the kidneys with perirenal involvement as well. And just one more example showing that. When we talk about lymphoma and back pain, here's a good example. Infiltration in the pancreas, extensive periaortic involvement, and left renal involvement and perirenal space involvement. Again, a range of appearances, but the ER may be the first place you see one of these patients, and here it is in the coronal view. So some conclusions and takeaway points. When we think about GU in the ER setting, we're thinking about hematuria, we're thinking about flank pain. Age of patients and clinical history may be helpful and is helpful in defining the optimal protocols. Is it a 25-year-old with likely stone or a 32-year-old female with likely pyelo as opposed to a 70-year-old male? We're thinking about bladder, renal, or even prostate cancer. One of the challenges in reading films in the ER, it's often a single-phase study because it's rule out abdominal pain or rule out anything, and you really don't have a great history. So it is a little bit challenging. Some patients may need to be rescanned. The communication between radiology and the ER docs is critical. We need the right history so that we can do the right study for each and every patient. And then once we see something, communication back to the urologist or to the ER doc is critical. Who needs to be worked up further? Who needs cystoscopy? Who needs a dedicated CT? Who needs a biopsy? All of those things become important. And again, the close collaboration between all of us in better managing the patient cannot be overemphasized. In this era where everyone seems to be overworked, the patients often suffer unless we work closely together. And with that, have a great day. See you later. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.